With us today, our first presenter is Dr. Ikol Alan. Dr. Ikol, he will start presenting on some of the emerging topics in maternal-fetal medicine. And maybe, Prof, you might pick up and start doing fellowship programs at KEMU. And without much further ado, let's welcome Alan Ikol to talk about ventriculomegaly. Hey, ventriculomegaly.
Thank you, Dr. Kigondu, for that introduction. And thank you all to the audience. I'm happy to be here. I didn't know that in Meru, 8 o'clock is 10. We were to start at 9. I was here thinking I'm in Nairobi. I get here at 8:45. Here we are. But I'm pleased to be here. And just to share with you what we normally do. As you have been told, my name is Alan Ikol. I'm a fetal medical specialist and also a gynecologist. And I'm based in Kenyatta National Hospital. At the same time, I do my private practice in Fifth Avenue. So we're going to discuss mainly these subjects, ventriculomegaly. I know as obstetrician gynecologists, this is something you always encounter on an ultrasound that is done by either a radiographer or a radiologist. And that's why it's something I thought, can we dig deeper into what is happening to this fetus who has been scanned? So that's the scope of the presentation, and we'll go directly into the presentation. We'll just start with the embryology first of the brain. As you all know, the embryogenesis starts with the meeting of two gametes, from the male and from the female. And you find from this, we have that the brain developing from the neural tube, which starts at like a small mass of 3 millimeters, but it goes ahead to produce almost 100 million neurons. So that's a marvel of engineering. And you find any error happening within these cells that are dividing from a 3 millimeter mass, that's from the neural tube, all the way to all those neurons. You find any exposure to environmental toxins, either X-ray, alcohol use, or fecal infection, can result to any abnormality happening within the fetus that is developing. But today we'll mainly be in the brain. As you are all aware, that image is mainly where the brain comes from, where it develops from. Starts from the forebrain and the hindbrain. And this whole activity happens at around 4 to 5 weeks of pregnancy. And you find it starts by the formation of just the primary vesicles, where from the forebrain, we develop the cerebral hemisphere, the hypothalamus, and from the midbrain, that's just a link between the fore and the hindbrain. That is the mesencephalon. And then from the hindbrain, that's when we have the development of the pons and also the cerebellum. So we find within the development, if any error occurs at around this early stage of 4 to 5 weeks, that's when we start having a problem. In terms of fetal medicine, I just wanted to highlight to you that there are a number of things that we do in terms of just screening any fetus for abnormalities. This can start as early as 10 weeks. That is, NIPT is mainly non-invasive prenatal testing. And this involves just taking maternal blood and checking for cell-free DNA, which is able to detect some trisomies. And you find from there, if you have either a patient who had a family history of either a brain abnormality or any other abnormality or a familial problem, we're also able to do an amniocentesis, whereby we just take amniotic fluid for screening. The other thing is in terms of, this is now universally being offered, quadri test, whereby we check maternal blood and we just try to screen for any abnormality. This can be done in all pregnancies because in terms of cost-wise, it has come down slowly. For now, almost 12,000, you're able to do a quadri test, and you're able to classify a pregnancy into a low risk or a high risk. For The other test is mainly alpha fetoprotein. This one we're also able to check either in maternal blood and is able to give you an idea of whether there's any CNS abnormality or either there's an abdominal wall abnormality in that fetus. And then for us, mainly we come in as fetal medicine, whereby we like to do a scan between 11 to 14 weeks of pregnancy. We call it a screening test, a screening ultrasound. If you have all those blood tests and then we do a screening ultrasound, we're able to see pregnancies that have a problem. And at between 20 to 22 weeks, we always like to do now a comprehensive scan. It was a habit in the past that people used to do scans between 18 to 20, but most times that scan is not comprehensive. I advise you we move to 20 to 22. For me, I prefer 22. Because 22 weeks, you're able to see the fetus very clearly, especially when you are thinking of doing any neuronal assessment of the fetus. 22 weeks are very nice time to do all that. So we'll go deep now into ventriculomegaly. You find that when you're scanning the brain, mostly this is the most basic scan of the fetal brain. You find the first one, does a light. Okay. Yeah, I know. Yeah. So you find that in terms of the first picture is just a representation of the okay. You find that the first picture is just a representation of the schematic representation of the fetus and how the fetus is scanned. You find that when you look at A, we call it a transthalamic plane. So we cut an axial plane on the brain. So we're able to see the ventricles. And that's when most times when you're told there's a ventriculomegaly, your sonographer has looked at the brain from that angle. The second plane, the other picture on the other side, is now plane number C. Plane number C, that's where when you are checking the head circumference or the biparietal diameter, when you are doing the fetal biometry, that's where the sonographer will assess. And then in terms of, we are mainly looking at the cerebellum. So this is the simple that every sonographer does before they give you a report to tell you, is this fetus fine or this fetus has a problem? In terms of just the background of ventriculomegaly, you find that when we're doing that plane that I've shown you earlier, and the sonographer detects that the ventricle is dilated, he will write that the fetus has a ventriculomegaly. But is that the end? No, that is not the end. That's just the beginning, because we are opening up Pandora's box. And that's why the title I said ventriculomegaly. Is it a sign? Or we need to dig deeper, because there is a cause for ventriculomegaly. And you find that in terms of most times, we tend to see this at around the second trimester ultrasound. That's when the diagnosis will be made, between 20 to 22 weeks while you are doing the fetal anatomy scan. Once he finds that, you need to confirm, is it bilateral or unilateral? And in most times, when we classify it into 3 categories. There is a mild ventriculomegaly, there is moderate ventriculomegaly, and there is severe ventriculomegaly. Most time, the severe ventriculomegaly, that's the dilatation of the ventricle beyond 15 millimeters, is associated most times with either an obstructive pathology or severe brain abnormality, or is associated with other fetal abnormality or genetic disorders. Moderate is in between, but for that fetus, we really need to look deeper to understand what is happening, because some of them are just transient, moderate ventriculomegaly, or some can also present as a very big problem within this fetus. For mild cases, you find most times we tend to have just a transitional mild ventriculomegaly, and most times when we see a mild one, we really try to scan that fetus, and most times it's just associated with actually sometimes when there's no abnormality at all, when they say there's a mild ventriculomegaly, because it's something we normally see. So in In terms of etiology, there are a number of causes of ventriculomegaly that I've highlighted, and you find that in most cases, when you find moderate to severe, a high index of suspicion of either a more severe problem in this fetus or a genetic problem in this fetus is something that we think about. This is just more of the causes I've highlighted before. What are the probable causes of when we encounter any of these, mild, moderate, or severe ventriculomegaly? Sometimes it's just a structural abnormality. Remember the way CSF moves from the lateral ventricles, moves to the third ventricle, to the fourth ventricle, and the Magendie. So, and then to the subarachnoid space. So you find any problem that obstructs that movement of CSF can result to a dilatation of the ventricles. So Chiari malformation, remember, mainly associated with spinal bifida. Posterior fossa abnormalities, you find that in the fetuses, there are also some tumors or sometimes some swelling in the posterior fossa. And due to a pressure effect on the posterior fossa, can result to either an obstruction of CSF moving from the third to the fourth ventricle, or can cause a disorder of absorption of the CSF into the subarachnoid space. Things like aneurysm, cerebellum agenesis, those are among the structural problems. In terms of fetal infection, it's something that for a long time, remember that when we used to do torture screening for recurrent pregnancy loss, but is no longer the case. Now in fetal medicine, we are taking up torture screening as among the things that can lead to ventriculomegaly. So anytime we find a fetus with an enlarged ventricles, we always like to screen for that, toxo, rubella, CMV, or herpes simplex. In terms of other neuronal migration disorder, there's something, you find that the neuronal cells, there's migration of the neural cells from the inside part of the brain up to the cortex. So you find during any disorder of neuronal migration, you find some of these fetuses may also have a silent sign of ventriculomegaly. So when you do a scan, 22 weeks, you find that the ventricles are enlarged. So these are the things we need to look at. In some fetuses, you find there's a condition whereby some fetuses have low platelets, and it can result to either intracerebral hemorrhage or intraventricular hemorrhage, resulting to more of obstructive hydrocephalus. So those are other causes that we need to look at. The image there is more of the cases that I've managed to see, and you can see that plane that I was telling you, the transthalamic plane. That's what you look at, and you find that the ventricle is dilated, that black part. So as soon as you have that report from the sonographer in terms of telling you that there's a ventriculomegaly, don't leave it at that and tell the patient, yes, there's just a ventriculomegaly. These are the patients we'd like to see for us to be able to know what is the cause, and for us to be able to discuss with the patient more. So you find, we'll try to explain the causative agents, and we'll try to do now a comprehensive scan. And this comprehensive scan helps us to look at a number of things. We'll look at the CNS, that's the neurosonography. We'll look at the heart, that's echo. We're able to look at the heart from the fourth chamber up to the outlet of the heart, where the aorta leaves the heart and up to the level of the pulmonary artery leaving the heart. We're able to look at the renal system of the fetus, because some of these genetic abnormalities are associated with either enlarged kidneys, or at the level of the kidneys, we find there is either obstruction, whereby there is dilatation around the renal pelvis of the kidney. We also try to look at the bladder, because some are associated with more obstructive pathology of the genitourinary system. And we also look at the intestines, because some of the fetal intestine, if we see any, we call it echogenic lesion within the intestines, whereby there is whiteness of the intestine, looks like bone. It is able to give us an indirect sign of that this fetus may be having a genetic problem. For some of the cases, MRI can become useful. This becomes essential, especially when we scan that fetus just with an ultrasound, and we find that the ultrasound isn't giving us any more details concerning to what we are thinking may be happening, or is not answering our questions. There's always room to do an MRI at around 32 weeks of pregnancy. In our case, we haven't adopted it yet because most times when you send for MRI, the radiologist will report to you that the fetus is moving quite a lot, so they can't get still images. So it's something sometimes that with time, we may adopt more of paralyzing the fetus, and then they do the MRI of the brain. So once you are able to diagnose what the problem is, classify either into a lethal abnormality or a non-lethal abnormality. The next phase of action is counseling of the patient, and after that is now mode of delivery. There are some ventriculomegaly that is associated with increased head circumference of the fetus, and you find if the head circumference is increasing significantly, we like to do a serial assessment of that head circumference. If the next scan, maybe we do at 20 weeks, we find there's a mild problem, we do a scan at around 35 weeks, the head circumference is within normal. You find for those patients, we'll advise you that normal head circumference, this patient can have a vaginal birth without any problem. But if we find that the serial measurement of the head circumference is showing increased head diameters, and any diameter above 40 centimeters, we always prefer that we have a cesarean section for that patient, because that fetus is not going to pass through the birth canal. So after all those complex words and all that, we go just to the cases that we have been able to assess to guide us on just that these are the things that we do, these are the things that you see every day, and this is how we approach some of these cases. So we'll start with case one. You find that this case, this was a mother who presented to me at around, I think it was almost 30 weeks. And she came in and we did, because she had been referred that the fetus had a ventriculomegaly. We managed to scan her and we confirmed that there was ventriculomegaly. You find that some of these images, so these are the first image shows a ventriculomegaly, that's the lateral ventricle. Where is it? The first image shows the ventriculomegaly. The second image, these are the level of the cerebellum. So we are able to look at the cerebellum and we are able to look at the space from the cerebellum up to the scalpel. This is a different section of the brain. So axial is the normal one, but we are able to scan the fetus in a coronal view. So we are moving from the face all the way back. And this is one of the images of that. Okay? So in terms of these fetus after we scanned, so we scanned axial, we scanned coronal, and we scanned sagittal. So from the sagittal view, we are able to assess the presence of the corpus callosum. Remember, the corpus callosum is just the communication between the two hemispheres of the brain. So that's at the right and the left. So from the scanning that we did of the sagittal, it was able to give us more information. And we came up with the diagnosis of corpus callosum agenesis, because on the sagittal plane assessment, we are not able to see the corpus callosum. The head circumference, serial measurements was normal. And from all this assessment, we were able to discuss with the patient, because we came up with the diagnosis that this fetus has a corpus callosum agenesis, and with corpus callosum agenesis, it's compatible with life. The only thing is that most times, in terms of neurodevelopmental achievement of milestones and a baby being able to do things for themselves, sometimes it's difficult. So you will able to counsel this mother that this baby, when it's born, in collaboration with the neurologist, will have challenges in terms of either being able to do things by themselves, being able to achieve certain milestones, and you find some of them even just have what we call cerebral palsy. All of us sometimes is a terminology, but you find those are the things that is happening. This fetus just lacks a corpus callosum, and so there's no coordinated movement. So there's just spasticity of the limbs. These are the other images, the same fetus. Once we did the neurosonography, we are able to scan the other parts of the fetus. So this other image is mainly of the spine, because we only time you see a ventriculomegaly. Remember, the brain from the neural tube forms the brain and the spine. And the spinal cord. So any complete CNS examination, we have to follow up with a spine assessment. That's just a spine assessment. The third image is mainly the heart assessment. This is looking at the outflow of the heart. After the 4-chamber view, we look at how blood is moving out of the heart. And then this is more at the level. After that image, mostly we get this picture. And we call it a 3-vessel and trachea view, whereby we just look at the aorta, the pulmonary artery, and the trachea. This is just more of the 4-chamber view. Every other thing in this fetus was normal, other than the brain. And the patient delivered normal, and the patient is on follow-up by a neurophysician, pediatric. So this is case number 2. Case number 2, you find that the image, this is the first image that we were able to get. Before that, these were the other images of the brain that we were able to get. So that is more of the axial plane of the brain, same axial plane of the brain. We tried different angles. The coronal and the sagittal is almost giving us something similar to all the axial planes. We assess the spine, because anytime you see this, you have to look at the spine. And in terms of fetal growth, we always look at the head circumference also. Remember, I told you it's something we like to do. And from all that, we saw that this fetus, in terms of severe ventriculomegaly, from the earlier slide, is associated with other genetic abnormalities. So we offered to do an amniocentesis on this patient so that we are able to counsel her more. Is this associated with either a trisomy 21? Because our working diagnosis was a lobar holoprosencephaly. And you find with a lobar holoprosencephaly, the risk of a fetal demise immediately after birth within 24 hours is almost at 90%. So we were able to discuss with this patient and tell her what are the risks involved. The patient wanted a termination of pregnancy at that time, but we counsel her that according to the law, beyond 28 weeks, we are having a baby. So we discussed further, and we did serial head circumference measurement. We spoke with her. We sent her to a neurophysician just to have a discussion in terms of what we are seeing and what are the chances of survival, what are the chances of functionality of this neonate once it's born. And based on what we had thought of in terms of survival, the baby was delivered by a CS at around 37 weeks because the mother came in preterm premature rupture of membrane at 37 weeks. And due to a big head circumference, we had to go for a cesarean section. Day 3 post-delivery, the baby had a shunt. The head circumference was big. I've forgotten how much it was. And in terms of day 3 post-delivery, unfortunately, the neonate passed on because of a lobar. We had not investigated more to confirm in terms of genetics. So you find, I saw this mother after all that event in terms of 2 weeks post-surgery, and I felt that based on the counseling we did early in the antenatal phase, she was doing better than the mothers who don't have that counseling at all, and they encounter they have such an experience, which is very hurtful, and they are not prepared for it.
But you say at what session you do the counseling?
We got 30 weeks.
30 weeks including the allowed admission?
The law.
You give a back that scout, well, no, the baby is not going to survive. You know, there are some, we know the law doesn't allow.
Yeah.
But abortion takes place every day. It's that, why did you not refer this patient to someone who can actually do that? We can do that.
The discussion will tell me. Is that good? And then this is case number 3. And you find this patient was sent to us because of mild ventriculomegaly. And we are able to do scanning to have these images. Where she was referred from, they had shown that she had a ventriculomegaly. So we did, that's image number 1. This is the axial plane. The other image of the axial planes of just the ventricle that has been measured was normal. That's the facial appearance of the fetus in terms of the face. And these are other assessments of the brain that we are able to do the different angles. That's the coronal plane that I was telling you, move from the face backward, and it shows, it gives us all that image. And these are the level of the cerebellum, whereby we are able to see the cerebellum, we are able to see the posterior fossa, and everything was fine. So for these fetus, we found that everything was fine. We advised that in terms of just assess, we just need to do another scan after 4 weeks to really confirm that everything was fine. And 4 weeks later, everything was good. So we allowed her to continue normal antenatal visits. And the patient is currently at around, I think, 38 weeks. We are waiting for delivery, and then we see how the fetus will do. But we didn't find any problem. And then this is case number 4. In terms of, these are the images, and you can find the head circumference was significantly big. She came to us at around, I think, 34 weeks with a big head circumference. We assessed the brain. We see this is also a case of aloba-holoprosencephaly, because you can see there is no interhemispheric fissure, or the falx is not there. We're just saying this is the thalamus. Okay. And then this is more just another image of the coronal view of the brain. And this is the 4th chamber of the heart. This is now a serial ultrasound. That was, I think it was 3 weeks or 4 weeks, I'm not sure. This is the head circumference now. And that was, we saw at around 34 weeks. We saw again at around 36 weeks. The head circumference had moved to 45. What was the mode of birth? Cesarean section, because the head circumference is more than 40 centimeters. But remember, aloba-holoprosencephaly. She came at 34 weeks. So still, we'll discuss that at the end in terms of the ethical dilemma. And that's why even I was raising all this. Because you are the practicing obstetrician gynecologist, you see these patients every day. So that's the ethical dilemma we had. We confirmed also she had a cleft lip. Most times when we see this aloba-holoprosencephaly is associated with trisomy 21. Sometimes to add more meat to what we have, we offer invasive testing where we do an amniocentesis, and they go either for a karyotype testing, because this is targeted. Karyotype at least is less costly compared to you just doing an extended panel of genetic testing. Because based on what we are seeing, we are thinking is a karyotype. It's a trisomy 21. So when you send for a karyotype, they check for 21, 18, 13. So you find it's more or less costly for the patient, and you're able to come up with this diagnosis that helps us to discuss with the patient what are our expectations. So you found that, unfortunately, also, we had to continue with the pregnancy based on, Wafula will discuss that. Based on what we found, we described to the patient, but the patient preferred continuation of the pregnancy. In terms of termination, we were held, we said it's possible, but according to the law and where we practice, We haven't had that. So it's something we need to sit down and also discuss further. Unfortunately, the neonate died 3 days post-shunting. So this is more just a guide or action plan. After we detect that we are having ventriculomegaly, what do we do? So you find that now as we have said, we have to determine what is the underlying cause, what is the severity of this pathology that we are seeing, this sign. Is it just a mild ventriculomegaly? We scan, we find the fetus is fine. Are we having a moderate and severe ventriculomegaly? We have to do a full fetal assessment. We have to do a neurosonography. We have to do an echo, and we have to do abdominal assessment to ensure that everything is fine. We have to look at the spine. We have to discuss with the patient about mode of delivery because of the increasing head circumference. We have to discuss with the patient about shunting after delivery, especially if there's an increasing head circumference. And we bring on board even the neurologist just to tell us that if they are to do shunting, what is the cost and cost implications, and what the procedure explained to the patient that what is needed. And then for any case with ventriculomegaly, mild or moderate, remember is associated with other genetic abnormalities. We always offer invasive testing whereby we do an amniocentesis and we take the sample for either karyotype or an expanded panel, the microarray. And remember, for some of these lesions, like alobar holoprosencephaly or semilobar holoprosencephaly, its association with mortality within the first 72 hours post-delivery. Are we able, or does the law allow us to discuss about termination? So the take-home message is that anytime we have a ventriculomegaly, think about all the multiple causes of ventriculomegaly and think about that more can be done for us to confirm, is this an isolated ventriculomegaly or is it associated with other pathologies? Those are the images, like the upper image is just showing us the sagittal plane assessment of the corpus callosum. So when you say a ventriculomegaly, we always like to do that plane, the one that is up there. And those are just what we look for and the labeling of what we find. And the other image is mainly the image of the assessment of the brain. What do we look at? We look at the brain from front to the back, and we look at the sulci of the brain, and all those images are things we interpret. And just a take-home message is that ventriculomegaly is just a sign. It's not a diagnosis. It's a sign that we need to look for more to confirm that this fetus is okay or this fetus has other problems. Those are just my references. Thank you for your time.
Good. I've put that discussion just before tea. After this, you go tea. So then we come back. But one of the reasons we put this presentation early in the morning so that people can discuss, as you have seen, the sort of things we need to keep thinking about, putting in policy and law. As you already hear from Wafula Nyongesa, there are those discussions that we need to have. Just to put in context, if you remember the Meru training, the presentation by the Meru team on point of care ultrasound yesterday, I think you are now starting to see why it is important to have, for people to have access to early ultrasound so that you are able to make decisions early. Nyongesa has brought in a very, sort of obvious point. If at 20 weeks, for instance, you relatively sure, of course, it's easy to make an assessment on the one you are sure of. So, for instance, if you know that this fetus at the time of delivery will die or will not reach, it's easy to make a decision, but you must have been able to, it must have been detected. And one of the limitations of the detection is a lack of an early ultrasound. That's one. Number two, we've also seen the quality of ultrasound. Saa zingine unaambiwa normal, you see? And it's not normal. And then what is the medical legal implications of that? Yeah. And then now the law issues. Can you make propositions on that? With that, I want to open the floor to comments and discussions and questions because the maternal-fetal experts are here. Before we go for a break, then come back for the second session. Nyongeza.
Yeah, Dr. Ikol, thanks. Can you hear me clearly? Thanks so much for that presentation. Okay, two observations. One, as you have said, this sometimes when you make a diagnosis of ventriculomegaly, it brings some extra dilemma in there. Because I'll give you a scenario. There is a friend of mine in Mombasa who had a baby. She was a 1 + 0.2. At 20 weeks, a diagnosis was made of some mild ventriculomegaly. Then, because she was so annoyed, at that time she had separated with her partner. She became quite emotional. So during the baby was followed up, of course, and the ventriculomegaly was quite severe. Then, when she was because she had a previous scar, she wanted an operation with the tubal ligation. So she came to me, I refused. I told her I cannot do tubal ligation. Because you see, she was acting out of emotions. And I don't think she was ready for that tubal ligation. Then she abandoned me and went to another colleague who offered her tubal ligation. So when the baby started growing, actually the baby became normal. All milestones developed normally. Then after 3 years, she comes back to me. She wants reopening of those tubes. She was reversal. So I told her it's a bit difficult. Maybe you'll try IVF. Because reversal is not a guarantee. Yeah, that's one. Now, the other dilemma is what you have just discussed about giving a scar to a woman who you know very well that this baby will not survive. But you could have done something earlier on. At 30 weeks, I don't know how big the head circumference was at 30 weeks, whether it could have been very difficult also to deliver vaginally, or I would have required maybe destructive prenatal so that you could be able to deliver. But I know of colleagues who can do this job in Nairobi. When you are faced with such a kind of dilemma, you can actually quietly call them and tell them, I have this situation. Is there something which you can do? And they actually do it. I cannot disclose their names, but I know them. And they have done good work in this area.
Thank you very much, Dr. Fuller, for your comments. We look at, you see, especially when you're in a structured system of work, we look at a number of things. Because if you encounter this patient, actually the message from me to you is that let's catch these things very early. That is the take-home message. Let's get it very early, whereby at least the rules are not as stringent as finding this thing in the 3rd trimester. Because I'll give you a case scenario in terms of, there's a case of severe ventriculomegaly. It was thought that this fetus wouldn't pull through. A termination of pregnancy was offered, but an ideal termination in Europe, an ideal termination involved, if you scan this patient, is less than 35 weeks. A termination is allowed in some of the European countries. What they normally do, they do intracardiac potassium chloride, and there's a fetal demise. Once there's a fetal demise, they induce you. What is done in Kenya is different. People start just induction. Induction, and then you produce a fetus who is kicking. What do you do? Do you abandon the fetus to kick until its last breath? Or do you take this fetus to NBU? We did that. The fetus was taken to NBU. The fetus pulled through beyond that 3 days we are talking about. So you find in terms of the ethics that we really need to bring forward is intracardiac fetal feticide. Is it allowed in Kenya? Which is not allowed in Kenya as per now, intracardiac. The only cases, sometimes we always have our own fetal medicine sessions. At least Aga Khan has a mechanism of having a medical advisory committee. So each case is dealt with individually. But you find in the public institution, we don't have that. So it's something we really need to sit down as public institution. If you are doing a termination of pregnancy at 34 weeks, you decide that is the treatment. Can we do the right process and procedures? Not producing a fetus at 34 weeks and the fetus is looking at you.
So for the biggest, some of the biggest sort of dilemmas in obstetrics is the unsureness. You know, as much as you may predict, it does not necessarily come out that way. You get so those dilemmas. And there is a presentation that is coming at it's 11 now, 11:45 by Dr. Deepak, and that will bring out some of these dilemmas that you're talking. So for Nyongesa, it's not as obvious as it looks. But what I've learned, and I've been working with a lot of maternal-fetal medicine, and I really appreciate that course, is the follow-up. And then, as he has put it, what Aga Khan has put in place and other institutions need to adopt a multidisciplinary approach to the management of that. You as a physician are not God. You cannot make a decision. 2, involvement of the person who is carrying the baby. You see, then so you put policies in place, you involve the family, and your role is actually to give in as much information as possible, and then the law. You can also, you know, be in trouble with the law, thinking that you're helping, you know, alafu unarukwa, unaelewa? Yeah, so those are the dilemmas. So we have no answers. So in fact, one of the things medical workers should stop thinking about is that they are the ones with the answers. You know, answers sometimes come from discussions. Any questions more from, hauna swali ya maternal-fetal? Medical students, you have any questions? Professor.
Thank you. Thank you, Dr. Ikol, for the good presentation and even for the update. I'm wondering, is there any room for surgical intervention intrapartum? Must we wait for the baby to be born so that we do the shunting or the other thing which we need to do? Is it possible to have the interventions intrapartum? Because I'm sure if the moderate cases, and they could be assisted if there is.
In terms of for the ventriculomegaly, most times in the Western countries, they tried the intervention of shunting, especially for the ones with rapidly increasing head circumference. But the problem is in terms of the intervention was mostly through hysterotomy. And you find based on the hysterotomy and the other risks involved, preterm labor and all that, they saw that the risk outweighed the benefit. The only thing that they have been able to make milestone in terms of if you find a fetus with ventriculomegaly and then you scan the spine, you find the spinal bifida. They are able to do spinal bifida repair because it has been shown that for those fetuses that you do the spinal bifida repair, there is less, it has been shown when they are followed up later on, especially the ones at the lumbar sacral region, there is lower risk of bladder control. So they have better bladder control. There is lower chance that they'll require a shunt later in life.
So that's the main thing in terms of spinal bifida. But for ventriculomegaly, it was shown the risk outweighed the benefit. Yeah. No, that's what Professor was suggesting. Is it possible they do shunting? Yes. But now you see it involved removing the fetus, put the shunt, return back. But for spinal bifida, it's being done, some laparoscopic and some open. And they do the repair, they return the fetus. And they have been able to push pregnancies. They like doing it around between 24 to 28 weeks. And then they return the fetus, pushes up to 34 weeks. Yeah.
Thank you. Na Ikol apewe makofi. Thank you very much, Ikol. Thank you. Thank you.